cell phone, now's the time, right? All together. Now, the only ones allowed to keep the cell phones on are those that are waiting for a heart in case you get a call. But the staff is here, they'll tell you. So if you would, turn them off. What a great facility. I mean, we've had a couple different presentations, different areas. Each time they take us someplace different, and wow. I said to Deb this morning, I said, 80 people responded that are coming. Are we going to be able to fit that in the room? Because I don't think it's going to be a problem, Jim. Not a problem. I was just telling Dr. Jessup, it's amazing all the stories that are in this room. And I have been so blessed over the years. My name is Jim Gleason, by the way. 18 and a half years, product of the great program here, and celebrating every day, as I know many of you are also. And so, welcome on behalf of Second Chance and the Heart Program here to another great program. Take a deep breath, sit back, and just enjoy. Dr. Jessup will become the president of the American Heart Association come July. She's the president-elect right now. You see that most got the memo of wearing red today. And so with that, I'll ask Dr. Jessup, come on, you know what you want. Look at the red on that. That's amazing.
Well, thank you, Jim, and I do want to give a special thanks, first of all, to the Solid Hearted Gold Fund, which sponsors this program, and then the key people that have provided not only a great source of help to all you, but to the nurses and physicians of the heart program here, our social workers, Debbie, Sally, and Claudia. They we can't do without them, and this is the kind of thing that they do without even thinking very hard about it. And if I could tell you all the millions of things that they do to help our individual patients and over at the transplant house, and I'd like to give a big round of applause. Now, I can't begin to tell you what it's like to look out and see your faces, because as Jim said, there are so many stories attached to them. Not all of you have gone through heart transplants. Some of you are spouses or significant others or children or parents. And some of you haven't even been in that line. Some of you have just had heart disease for a long time, and some of you may even be interested in how to move forward with the knowledge that heart disease is out there. So I thought I'd take the next half hour or so to talk about what I'm most interested in right now, and then we'll leave lots of time for questions. This is Heart Month, and it's a great opportunity to really talk about moving forward with or without heart disease. So, did you all know that fewer than 1% of Americans are in ideal cardiovascular health, but about 40% of Americans think they are? There's a problem. That 82.6 million adults in this country are living today with some form of cardiovascular disease. So we're not alone. And if misery loves company, boy, we are not miserable anymore. Each day, an average of more than 2,000 people have a stroke, because stroke is cardiovascular disease as well. As we talk about the budget endlessly and the sequestration and all those things that we don't understand, cardiovascular disease is our nation's most costly illness, accounting for $298 billion. I don't even know what that looks like, in direct and indirect costs each year. This cost is projected to exceed $1 trillion by 2030. But let's get to the personal. Every 34 seconds, somebody has a heart attack. Every 40 seconds, somebody has a stroke. 2 out of 3 adults in this country are obese or overweight, And here's the real crime. Childhood obesity has tripled in the last 3 decades. Half of adults in this country have high total blood cholesterol, and 1 of every 3 adults has high blood pressure. 95% of Americans will have high blood pressure at some point in their life. So what if you had a guide that would guarantee you or the person you love a longer life? And let's just talk about our children or our grandchildren. What if we could prevent heart disease? What if we could all feel stronger and healthier now and later, or have this for the people we love, and we could provide a better quality of life as you and your children and your grandchildren invest in your relationships and life goals? And so what I want to say to you is, this is not pie in the sky. This is possible, and I'm going to just talk about some simple tools as a way of tackling this problem, which I find very useful. These are the kinds of tools that we try to use in our heart failure program, our heart and vascular program here at Penn Medicine, and which we've partnered with the American Heart Association to use. And so I want to go through that a little bit better. And we call these Life's Simple 7. Now, the mission of the American Heart Association, which is very allied to the mission of the Heart and Vascular Center, is that we want to build healthier lives free of cardiovascular disease and stroke. And we put our mouth and our money on the table and say, we've set ourselves up for a goal. So our goal at the American Heart Association is to improve the cardiovascular health of all Americans by 20%, while reducing deaths from cardiovascular disease and stroke by 20%. That's all Americans, young, old, black, white, Hispanic, all Americans, even illegal aliens that are living in this country, all Americans. And we propose to do this through looking at sort of 7 simple tools, which we've called Life Simple 7. Now I want to tell you a little bit about a really nice tool, and in case you didn't get it already, I mean, some of this is a little bit of a paid advertisement for American Heart Association, but as I said, the goals and the mission is so allied to what we do here at Penn Medicine that I'm using that license. So My Life Check, if you Google My Life Check, or it's on heart.org, which is the main website of the American Heart Association, and it's a really nifty tool. They'll ask you for your first name and your zip code. This is not designed to track you individually, but provide a resource for you or the people you love, or your children, or your grandchildren. And what you'll see on the website is sort of My Life Check, a success plan, and it goes through sort of 5 steps. You answer questions about your own Simple 7, you choose an action plan, you discover your score, you print and save your results, and you return periodically. So you'll say that we're not trying to say that this is not about you. It's about you taking charge of your own health. And so let's define, therefore, what is ideal health that less than 1% of Americans actually have, but 40% of us think we have. What is ideal health? Well, first of all, it's the absence of cardiovascular disease, or any disease. 2, there's favorable levels of health factors, which I'm going to talk to you about. You have favorable health behaviors. You all know what that's going to be about. And then the idea is to get away from talking about risk and disease. Yes?
Oh, I'm sorry, I'm waving the car off.
Oh, okay. We'll let you in. Talk about a story. So, you know, although we do talk about transplant and we talk about heart failure, the idea of our ideal cardiovascular health is really to focus on health rather than disease. And it's sort of a more positive framework. And as the mother of a 21-year-old daughter, my daughter doesn't want to talk about heart attack. She doesn't want to talk about stroke. She wants to talk about health and feeling good and well-being. And so I think, especially as we do reach out to younger people, it has to be about positive things rather than if you eat those potato chips, you're going to get a heart attack. It may be true, but that's not what they're going to listen to. This is what the website looks like. You just answer a few simple questions. There's always little spots here where you can, this for instance talks about what's congenital heart disease, and you can click on that. You go through, they're pretty simple. They ask you how much fruit do you eat, how much vegetables, how much fish, do you eat whole grain, so it's really trying to take a little bit of a dietary history. It asks about your blood sugar, your blood pressure, and your cholesterol. Well, you might say, well, I don't know that. Well, shame on you, because you're supposed to know that. That's part of the deal. In order to answer this, you need to know your factors. And then it gives you sort of a simple assessment, tells you your next steps, and where you want to be, gives you your goals, and it gives you a score. So the best score is a 10. This person got a 5.7 because their cholesterol needed improvement, their blood pressure needed improvement, their blood sugar was perfect, they don't smoke, they need a little bit more activity, their weight, not so great, and the healthy diet needs some improvement. So there's a lot of work, but that means there's a lot of opportunity. And you can get this, and then there's lots of information about where do I start, how do I go about this. So where did we come up with these 7 health behaviors or factors? And you all know these, but I'm going to go through them. Why manage blood pressure? High blood pressure is the single most significant risk factor for heart disease. It's the most significant risk factor for heart failure. It's the most significant risk factor for coronary artery disease, blockages in the arteries, and the most significant risk factor for stroke. And 1 out of every 3 American adults have high blood pressure, but most don't even know it. And how could you not know it? That's because you didn't go get your blood pressure taken. So you need to get your blood pressure taken. It's part of knowing your numbers. What's the action? Know your numbers. Track your progress. Learn healthy habits for eating well. Get active. Why do you have to get active? Because people who exercise have better health than those who do not. Countless scientific studies. What's the action? Make your decision to get moving. Build exercise into your day. You don't have to get into the spandex and go to a gym. Park your car at the other end of the parking lot instead of driving around 10 minutes trying to find a close parking space. Force yourself to walk a little bit. Take the stairs instead of the elevator. Go up and down your own stairs if it's snowing. Choose activities you can enjoy. If you don't like getting on a treadmill, don't get on a treadmill. But do something that you can enjoy. Controlling your cholesterol. Why? When there's too much cholesterol in your blood, you're at major risk for heart disease and stroke. This has been proven by countless studies. And there's terrific drugs that lower cholesterol. How do you go about taking action? You follow your healthcare provider's advice. You make good health food choices. You get active. As you active, you change the balance between the good and the bad cholesterol. Eating better. Why? Because heart-healthy nutrition keeps you living at your best health potential. And this is where we have an opportunity with our young people. What's healthy, what's not? What's a good choice, what's a bad choice? What are the actions? Say yes to lots of fruits and vegetables, whole grain carbohydrates, fat-free and low-fat dairy products, fish with omega-3 fatty acids, and no to food and beverages with added sugar and sodium. And this is one of our big factors that I'll finish with talking about what we're trying to do in our schools, getting high sugar-laden products out of the vending machines, out of the cafeterias, teaching kids about where there's a lot of sodium, simple stuff that may feel, I don't know if any of you have heard about this expression called the nanny state, where the government's trying to get in control of us and controlling how much sugar we have and sodium we have. Well, guess what? The food products we buy is what's controlling what we eat. Have you all tried to go out and buy low sodium food? It's getting easier, but it's not that easy still. Everything's got salt in it, and lots of things have sugar. So it is why you have to turn to fresh fruits and vegetables if you want to be careful about sugar and salt. Losing weight, our favorite subject. You know, we talk about weight as a BMI, which is body mass index. It's a simple formula that you can use that takes into account your height and your weight. That's why we always say in the office, you have an ideal weight. It's just that you have to get a lot taller for your BMI. So a BMI of less than 25 is optimal. For those of you who have struggled on the transplant list, we won't even transplant somebody if their BMI is too high. So some people have to go home and lose weight in order to get transplanted. That's how important body weight is to all overall cardiovascular health. So how do you go about losing weight? You invest your energy in the task and stop feeling guilty. Stop feeling bad about yourself. Know what your BMI is. Know how many calories you need, and then you reduce your calories in and you spend more calories by activity. So they're all interrelated. Don't smoke. Nobody in this room smokes. I'm convinced nobody smokes in this room. But why shouldn't we? Smoking is the #1 modifiable cause of death. #1. If you want to not die, the first thing you have to do is not smoke. Take action. There's lots of new products out on the market to help you stop smoking. Focus on the rewards. I know one woman who stopped smoking for years. She redid her entire kitchen. That's how much money she saved by smoking. And plan your response to roadblocks, meaning like if you decide to give up and your wife doesn't, you're going to have a problem. Now, I'm not advocating a divorce, but that's going to be a roadblock, so you have to think about what you're going to do. Reducing blood sugar. Why? High blood sugar encourages the growth of plaque in your arteries and increases your risk for diabetes, heart disease, and stroke. See how these factors are all interrelated? Take action, make good food choices, commit to regular physical activity, maintain a healthy weight. This is why it's so critical for our children and our grandchildren to not eat these sugar-sweetened beverages, not eat these high sugar-laden foods. So here are the metrics. Now this is a little scientific, but I wanted to show you that we've actually categorized, and there are ongoing registries being done by a number of government-sponsored things. So we're being tracked, whether you like it or not. There's money that's being spent, not by the American Heart Association, but a number of different research projects to follow all Americans. And for the purposes of these 7 factors, we call them poor, intermediate, or ideal. So for example, for smoking, if you have a poor health behavior, you're still smoking. Intermediate is you quit less than 12 months ago, and ideal is you never smoked or you quit more than 12 months ago. Did you know that even if you smoke for years and you stop for 10 years, it's as if your body never smoked. You get rid of that risk factor. It's cool. Diet, so here's leisure time physical activity. Poor, you don't do anything. You sit and you're a couch potato. Intermediate, you do 1 to 149 minutes per week of moderate or vigorous. So how does that divide up each day? 20, 30 minutes. It's not that bad. And then ideal is more than 150 minutes per week. Body weight, I already went through. Glucose, it is a little more scientific about what's poor, intermediate, and ideal. Why is this important? Again, this is some science behind these 7 factors. Along this axis, you'll see the number of ideal health metrics. So the higher the number, the more the ideal health. And on this side is the incidence of cardiovascular disease. And this was a study called the NOMAD study. What you see is the higher the ideal health factors, the lower the incidence of cardiovascular disease. That's for the whole group, whites, blacks, and Hispanics get thrown into a big pot just because they all speak Spanish, and there are a wide variety of people. So in this case, they looked at Caribbean Hispanics. Here's a very similar analysis looking at stroke. The more ideal health metrics you have, this is stroke, this is heart attack, the better you are, the less chance you have of developing any of these. So these are modifiable risks. You can prevent disease. So this ideal health is so important that the statistic is, and I agree, I understand who I'm talking to. Maybe the train left the station for a lot of you. But again, there's a future. And we have people we love. If you can get to the age of 50 in ideal cardiovascular health without any of those risk factors, the chances are you will live another 30 to 40 years without any cardiovascular disease. Think about what that means for our kids and our grandchildren. That if we can make simple changes, they won't have a lot of the disease that we've all had to struggle with. So the absence of risk factors, the sum of that is much greater than its parts. So that's the good news, that there's a possibility. Here's what's going on in this country. So this along here is the year, so this data was accumulated around 2009. And this and several other slides are sort of common sense. Red means bad, green means good, and yellow means caution. So here's what the prevalence of, this is for men, and looking at just the level of weight. So you can see that there's this issue of obesity. Look what happens if you go on out to 2019. This obesity is, and you've heard so much about it, and this is why the mayor of New York City said, I'm not going to sell any of these big gulps anymore, because it's just all sugar. This is why we got to get these sweet beverages out of our kids' schools. This is what's happening, is we're getting fatter and fatter and fatter. This just looks at body weight. This is 2006. This is what's projected if nothing happens. And this is what our target is for the American Heart Association, to reduce this, reduce death, and improve our cardiovascular health by 20%. Here's where the green is what we think is going to happen if no changes are made. Here's what we want to change. That's a lot of people to affect. A lot of work. So here's the projected burden between 2010 and 2030. And just looking at all cardiovascular disease, hypertension, coronary heart disease, that's blockages of the arteries, heart failure, and stroke. Look at the percent change as we go from 2010 over the next 30 years. If we don't make a change, the numbers are going to get worse and worse and worse. First of all, we can't afford it. Second of all, we don't want to pass that on to the next generation. And this is just a slide showing here's how much it's going to cost. We can't afford it. So as I said, our goal is to improve the cardiovascular health of all Americans by 20% and reduce death and stroke. Here's how we're doing so far. This is, I hope you can read this. So we're looking at children as well as adults. I personally think the future is with our children. So children overall, their overall cardiovascular health is improved by about 12%. That's really good news. Here's what we've done with adults. Not so good. Total progress to date in 2012 is 5.6%. How about reducing death? So this is improving health. Here's how we doing about reducing death and stroke. Coronary heart disease are down 14%. Stroke is down 10%. And total is down 10%. So we're doing well. We're on track there. But those gains are going to be offset by this. So let me just show you a few things. This just shows you how well we're doing with all cardiovascular disease, stroke, and coronary heart disease. There's really good news. What's that due to? Better control of blood pressure, better control of cholesterol, big, big efforts to get people to stop smoking. But here's the real issue. Now, these are very busy slides, so sort of stand back and kind of just look at the colors. So this, in all the slides, this is smoking, diet, physical activity, body weight, glucose, cholesterol, and blood pressure. So our 7 factors, our factors and behaviors. Here's men and women, and you can see that there's a lot of green. There's some good green, but there's a lot of red. And look where it's mostly centered around. Diet. Americans are terrible at diet. So the good news is we're doing a much better job with getting people to stop smoking. And how is this done? Peer pressure. Don't smoke in my area. Don't smoke in my office. Don't smoke in my house. And also advocacy. Getting states to, and cities and states to ban smoking so that you don't have to be near it. I just was in Greece, and you don't realize how free we are from smoke in this country till you go somewhere else. And you sit down and you think, oh, what happened? And it's because people are still smoking, although it's changing even there. And we're doing much better with cholesterol and blood pressure. There's no significant change in physical activity and diet over the first 6 years of our 2020 goal. None. We've done no progress. And we're worsening as far as body weight and glucose. Very sobering, isn't it? So, overall, we're improving smoking, high cholesterol, high blood pressure, no change, and we're worsening. So the projections is that instead of 20% improving cardiovascular health, we're only on target for about 6%. So it's okay if we fail, but we're going to try. And it's not okay if just white people living in the suburbs gets better. We want all Americans. So we want inner city blacks and other disadvantaged people. We want them to improve their cardiovascular health too. So we're determined that this is going to be a full American effort. So I'm just going to finish by talking a little bit about various programs. And the reason that I want to tell you about them is because many of you already do volunteer work. You're involved in Second Chance, and you're involved in other things. But there are programs even outside the American Heart Association, the American Stroke Association, but there are many, many opportunities within these organizations to get involved. And if you go on the website, all you have to do is say, I want to volunteer. But these are the full range of things that are out there. Remember, every solution has got to influence millions of people in this country. And the American Heart Association, or any organization, just doesn't have enough to go out. The American Heart Association has actually partnered with the American Cancer Association and the American Diabetes Association, all those letters, AHA, ADA, AZA. We're partnering together because guess what? The risk factors for heart disease are the same risk factors for cancer and are the same risk factors for diabetes. So we said, let's join forces together. So if diabetes is the problem in your family, go work for the American Diabetic Association, but work so that our kids aren't listening to this same lecture. So one thing that's happening is that we're teaching CPR. There's a really nice app for those of you who like apps called Hands Only CPR now. Maybe some of you have seen that you actually provide CPR with the same beat as Staying Alive, John Travolta. I know you all know that song. And you can get an app and it shows you how to do hands-only CPR. It gives you actually a beat to do the chest compression. It's a great app. Kids love it. I love to send it to the kids so they can do it. And our goal of the American Heart is to train 13 million people domestically by 2014. So if you don't know how to do CPR, learn how, hands only. It's really easy. We're trying to teach CPR in schools. All children should learn CPR. I just heard the other day, one school got up, they had 3 kids in their gym programs be saved because they use CPR in schools. Because heart disease strikes young people as well with some inherited diseases. In fact, Dr. Owens is here. She's our newest faculty member in the heart failure program. She specializes in inherited cardiomyopathies, and one of the issues is how to prevent sudden death. Knowing CPR starts that by saving these kids and getting them into health. We want to force our legislation to say it's okay to teach CPR in schools. And more legislations locally, statewide, are making that part of the rules of what gets taught. Teaching gardens. There are some kids that don't even know where vegetables come from, and Mrs. Obama has spent a great deal of time in her advocacy to eliminate childhood obesity, and she started a garden in the White House, as many of you may know, and there are a number of different corporations that sponsor teaching gardens in schools where there's a whole curriculum. They go in, they grow vegetables, they eat vegetables, they learn where it comes from, what it tastes like, and the kids love it. And think what an exciting thing this is for kids to learn about this. Even kids that aren't coming from disadvantaged neighborhoods. I mean, who knows about growing vegetables anymore unless you've lived on a farm? Where do they come from? And so our goal is to achieve 500 teaching gardens in elementary school. 500, that's a lot. Is it enough? Not at all. The American Heart Association has a food certification program so that when you go into a restaurant or a fast food place, you say, well, is there something healthy I can eat? They feel strongly that we should start to certify foods to say, this is safe, this has low sodium, this is low cholesterol, there's not a lot of added sugars. And that's a big program. Sodium campaign. Now, here's the weird thing. The American Heart Association says we should all follow a 1,500 milligram sodium diet. Everybody. How many milligrams of sodium are in a teaspoon of salt? 2,000. So it's less than a teaspoon of salt. Our government actually says you can be on 2,000 unless you're over 50 or you're African American. So that seems kind of confusing to me. So I can say, oh, wait, so when I was 49, it was okay to have 2,000, but now that I'm 50, I have to have 1,500. Oh, let me check my skin. Oh yeah, now I have to be on 1,500. That doesn't make any sense. So we decided we should just say 1,500. Now, if you start to read labels, you'll be shocked at how difficult this is. And I know most of you in this room have had to do that. And the answer is more fruit and vegetables. Fresh fruit, fresh vegetables. Walking paths. There's an app from the American Heart Association about walking paths. If there's a favorite place you like to, you can enter your walking path. You can find other walking paths, and it's a great thing. You can get on, you can see a place, you can measure how far it is. You can try it out yourself, you can make your favorites, but in particular in urban environments, where is it safe to walk? Where is it easy to walk? Learning all those things, teaching other patients, sharing that is great. Go Red for Women. Many of you have the little red pins. This is the 10th year of Go Red for Women. Why is Go Red for Women so important? What's the #1 killer of women in this country? Cardiovascular disease. It's not breast cancer. It's not any form of cancer. It's cardiovascular disease. And so many women say, oh, I got to worry about my mother. I got to worry about my husband. I got to worry about my kids. And I'll have time later on to take care of myself. So I don't know if you've seen the commercials on television about the woman, I'm having a small heart attack. It's a really great spot about that she's really busy and she's trying to send her kids out. And then she says, oh, don't worry, I'm just having a small heart attack. Some very good videos if you look about it. And this is our big effort to understand and help women. And in fact, we have a Spanish version called Go Red por tu corazón. which, because heart disease in some Hispanic neighborhoods is extraordinarily high, and women have more of a role not only in caring for themselves but their entire family. So it's a big effort. Power to end stroke. This is a very big effort to control high blood pressure and to get people to understand the warning signs of stroke. And the newest program is called FAST, and it stands for the stroke warning signs: face drooping, arm weakness, speech difficulty, time to call. Because time delay is brain gone. So just like heart attack, the faster you can get to care with a heart attack, the more heart you can save. The faster you can get to the care of a stroke, the more brain you can save. There's a great app here too that talks about FAST, and it shows a little drooping hand and how to call. So there's many, many good apps that are fun and are a good way of spreading the message. There finally, and I'm almost finished everybody, American Heart Association recognizes that there are systems of care that hospitals need to organize themselves so that they're ideally delivering the very best of care. Here at Penn Medicine, we've really invested a lot of time both in stroke care but in cardiovascular care. And these are being acknowledged. So hospitals that do really well go through a rigorous process where their sites are surveyed, their outcomes are surveyed, and they're given recognition. And we are a stroke center of excellence. We were, I think, the second or third advanced certification for stroke here at the Hospital University of Pennsylvania. There's actually a little map you can look to see where in your area these well-recognized hospitals are. And not only about stroke, but about other guidelines. So here at HUP, we're a gold for Get With The Guidelines heart failure, meaning we follow all the rules, and all patients that come into our hospital are treated in the very best of ways, and that's tracked. And we, again, go through a rigorous process. So it's not only trying to get people to take charge of their care, but hospitals and health systems to make sure they're delivering the very best of care and recognizing the efforts of that. And finally, there is something called Mission Lifeline to get patients that are having a heart attack to the fastest and the best hospitals. So there's Mission Lifeline receiving centers and Mission Lifeline treating centers, because some places you go to are not optimally able to treat your heart attack, but they know how to get you ready to go to a hospital that can. So this is a whole other system of care that needs to be optimal. So I'll finish by saying that these are the key factors and behaviors. These are life's simple 7. It is simple. You have to make up your mind, but the most powerful thing is that if you can make some small changes, you can impact dramatically your family, your loved ones, your children, your grandchildren's impact in not ever developing cardiovascular disease. I think that because this is Go-Red for women, the study that I like most of all is a group of middle-aged women that if they paid attention, so if they didn't smoke, they got a little bit of exercise, they kept their weight under reasonable control, they had a healthy diet, and here's the best part, they had at least a half a glass of red wine every day. Their incidence of cardiovascular disease was reduced 80%. Now, yeah, exactly. So 80%. I mean, where else can you get a reduction of 80% doing anything? Simple things. So these are the key. There's lots of hope. You don't have to get into those really tight exercise clothes. You just have to go out and walk and share the good message. These are the end of my formal remarks. I bet you have some questions, and I hope you have some questions, and I'm happy to answer those. So thank you very much.
Hi,
I clapped because I was going to ask you the question of where does the role of alcohol play? I know that 2 glasses for a man and 1 glass for a woman a day is okay, but can you comment further about
Sure, that's a great question. So alcohol, like everything else that's good in life, is sort of a double-edged sword. So it is true, if you look at big epidemiology studies, the more alcohol you drink, the less chance you have of having blockages in your arteries, so atherosclerosis. But there are clearly patients that drink a lot of alcohol that get heart failure. So heart failure is, of course, different than atherosclerosis. And if you drink a lot, you also are much more likely to get liver disease or cancer. So like everything else, it has to be moderation. You don't have to drink alcohol to prevent coronary artery disease, but we'd rather have you have a little bit of alcohol if you enjoy it, than having, a sugar-sweetened beverage. So I think that we don't, especially for patients who have heart failure, we don't want patients drinking usually more than about a drink a day, maybe only 3 times a week or so, because alcohol can make your muscle of your heart somewhat weaker. On the other hand, as part of a normal, healthy diet, especially red wine, in moderation, not this glass, but this glass, is reasonable and safe. Yes?
How about alcohol for transplant patients? Is that a no-no?
Well, there's 10 of us in the transplant program, and we all have different answers. So I would advise you to ask me, because I'm more liberal. Don't ask Brazil, she's really tough. So. I've been practicing together for 30 years now, and she's much meaner than I am. Again, we usually say moderation, no more than 1 drink a day, not every day of the week. 1 drink, not this drink. Yeah. Yes?
Does red wine used in cooking count, or only if you drink?
So that's a good question. I mean, a lot of times, we don't know what it is about wine that's helpful.
Okay.
And usually when you put it in the cooking, you use up the alcohol part of it. So it's not clear what is the helpful part.
I have one more.
Yes.
I know the importance of sodium, but this is something I've noticed because I have a son on dialysis.
Yes.
A lot of low sodium foods, they put potassium in,
Right.
but not all food companies list the potassium,
Right.
which is not good for anybody who's on dialysis.
Yeah, I'll repeat the question because I don't know if everybody can hear. So the question is, a lot of manufacturers, to reduce sodium, put potassium, and there are salt substitutes that actually have potassium in them. So if you have problems with high potassium, or you have kidney failure, or on dialysis, you really have to pay attention to that. A lot of times you can go on a website and look up the food, with Google, and they'll tell you how much potassium is in it. Yes. Wait, now you're pushing it, Lynn.
No. This is information.
Pardon me?
Wegmans, on their brands, list the potassium.
Oh, that's
They're one of the
Wegmans.
few people.
So the other thing that I should say about sodium is sea salt is also sodium, and low salt is also sodium. All of it is sodium. It all counts. So, yes.
Dr. Jessup, is it true that as you age, it's harder to take off weight as you age? When you hit a certain, no matter what you do, you can exercise 90 minutes every day, you can diet, but it's still harder to take off weight as you get older?
So, last week in the New England Journal, which is, our Bible, there was a great article in there that talked about the myths of weight loss, or the myths of obesity. And they didn't answer that question. Now, I'd love to say that when I was young, I thought that was a lot of malarkey. Now that I'm old, I think it's absolutely true. But I think that, in fact, what the issue is that we're less active and we eat more poorly. So there are lots of healthy people, even sitting in this room, who are in their 70s and 80s. Not every transplant patient gains, 60 pounds. Some people keep their weight nice and slim and trim. So sure, genetics has to do with it. But I think that the reason that we put on weight as we get older is that we don't try as hard and we're not as active.
May I ask a follow-up?
Yes.
When you talked about BMI,
Yeah.
For an individual that is, say, 6 foot, 6.5 inches tall, big bone, and you do a BMI, and the number comes up, you should weigh 220 pounds, and you say to yourself, in your dreams.
Right.
Does that
No, so the body mass index is supposed to take into account your height and your weight. So Mike Acker, who most of you know, who's very big, every time we have an argument about who's overweight in the training, he says, well, then my BMI is too high. And of course, he's very thin. So I think that you have to use this as a beginning conversation. Some people probably do have heavier bones than others, but in general, it usually means that they're overweight. The bad news is they're usually overweight. I always ask people how much they weighed when they finished school. And they kind of look at me like, oh, she can't possibly really want to know that number. Especially for men. I mean, most men are, when they finish high school, or especially, or they're in the service, or they say, I weighed 110 pounds soaking wet. And we say, right, and what are you now? You're 250? I think there's been some weight gain on there. So.
Dr. Jessup.
I've just been reading an article by this doctor who wrote a book about the myth of cholesterol, and he went into a whole thing about cholesterol isn't the risk for heart disease that other things are. But what he was talking about basically was too many people are on cholesterol-lowering medicines, and part of it is political. That's his thinking.
Right.
And what his thinking is that the cholesterol-lowering medicines cause a lowering of the effects of CoQ10. And his theory is that everybody who's on a cholesterol-lowering medicine should also be taking CoQ10. How do you feel about that?
So I think that there's lots and lots of stories about cholesterol. I mean, when I first started to practice cardiology, people weren't completely convinced that lowering cholesterol would in fact decrease cardiovascular disease. Now that's a reflection on how old I am, but it's also a reflection on the number of studies that have been done. I can say to you with my hand over my heart that I am completely convinced that there is a link to cholesterol and cardiovascular disease. There's no question about it. One of the reasons why the incidence of cardiovascular disease has gone down is because we have paid attention to this link. Now, the best way to lower your cholesterol is through a healthy diet. Again, because of the data I've shown you, that's not the kind of way people want to do it, and the drugs are extraordinarily effective. That's where we then get into the controversy of, what are the adverse effects of these drugs, and what should you been taking, and the CoQ10 or the coenzyme Q10 is something that comes up over and over and over again, and has been studied in one or two scientific studies that I know about, and they couldn't really show any benefit of adding it or not. Many of my patients over the years have felt strongly about taking it. As far as I can tell, there's no adverse effect from it, but I don't routinely tell people they need to take it. But some people, there are a number of authors out there that really spend a lot of time talking about coenzyme Q10. I think one of the things that the doctors, that we all talk about is I have patients that come in and they say, I just hate all these drugs, the pharmaceutical companies are trying to convince us to take all these, and then they bring in their pills, and they're on 10 or 15 over-the-counter medications, and I said, well, I thought you hated all drugs, but these are drugs being made by a variety of people that aren't being regulated at all. They have no oversight by the FDA. Some guy in his garage could be making this for all we know. And you're taking 15 of these, but you won't take anything to help lower your blood pressure. So, it's a push-pull that patients and clinicians have about what are drugs. And we have a psychological problem about taking drugs. So over the years, see if you can help me with this. I know what to say to women. I say to women, like, I bet you have 12 different kinds of lipstick and you don't get upset that they're all sitting there, or 4 other pieces of makeup. But I don't know what to say to men as an analogy. I know my dad had about 80 different tools that he used. You know, maybe he used one of them every once in a while, and he always wanted to have a lot. So I always tell patients, don't get excited that you're on a lot of pills. It's what you need. Don't count all the pills. Just use them. Yes?
Is cardiomyopathy a disease that can be passed on to your children, that you should be concerned about?
That's a great question. So the question is, can cardiomyopathy be something that you can pass on to your kids? So cardio is heart, myo is muscle, and pathy is pathetic. So cardiomyopathy is a pathetic heart muscle. And there are many different kinds of cardiomyopathy. In this country, if you have, there's cardiomyopathies where you have a weak, flabby heart. That's what it causes most people to end up having a heart transplant. That's called a dilated cardiomyopathy. There's something called a restrictive cardiomyopathy where the heart squeezes well, but it doesn't relax very well. That usually is, we don't know the cause of that, and is usually picked up in children, sometimes in adults. And then there's something called hypertrophic cardiomyopathy where the heart muscle is very thick and the heart squeezes very vigorously. And that is almost always a genetic abnormality. Sometimes you inherit it from your family and sometimes you don't. Now, of the dilated cardiomyopathies where the heart muscle doesn't squeeze very well, about 50% of people in this country have it because of blockages in their arteries. And when you get blockages in the arteries, coronary artery disease, because you have hypertension, you have diabetes, you smoke, you have high cholesterol. So for those factors, some of those can be passed on to your kids, but we don't think of that as inherited. The other 50% where their arteries are normal, we now think maybe as many as 40 to 50% of people have a genetic abnormality. We didn't used to. We used to say, oh, you had a virus attacked your heart. We now think that's probably not true. We think that probably you have an inherited disorder. And again, that's what Dr. Owens does. So she works with a genetic counselor. And we can do gene testing. Now, do we know all the genes that cause diabetic cardiomyopathy? No. But if it's something that you want to explore, that's what the program does. And in fact, Dr. Owens has a corollary group over at Children's Hospital. So sometimes we find it in the kids, and we have to test the adults. So the kids get picked up at CHOP, and they send the adults over here, and vice versa. We've had patients who have had a dilated cardiomyopathy have kids, we send the kids over to CHOP to get screened and followed. So this is a very growing recognition, and it's a terrific question. And many of you who have dilated cardiomyopathy, we have advised you that you do need to talk about it with your doctor. Is this something that could be in my children or grandchildren, or sisters and brothers?
Thank you.
Yes?
Regarding like diabetes with the sugars, what's your opinion as far as like regular sugar versus the raw sugar in the raw, the artificial flavoring, especially the controversy with the artificial flavoring being a cancer-causing agent?
Right.
What's your opinion on all that?
So sugar's sugar, whether it's raw or not. So and I think so that there's no real advantage of having fancy sugar or brown sugar. It's all sugar. I think that there is some data that says that if you drink a lot of, we'll say Diet Coke, that's kind of a generic term nowadays. There is some data that if you are one of these people that have 10 Diet Cokes every day, that there's some health consequences of that as well. So I think it goes back to the common sense sort of recommendation. Learn to like food and water the way it tastes, without adding sugar, without adding salt, without having colors in your water, and just learn to drink water and milk and low-fat milk, and rather than try to use the substitute sugars. Thank you. Yes?
Further to that point, vegetables and fruits, they have natural sugars in them,
Sure.
so that's not being contested then.
Right.
It's okay to Is that measurable, or do you just, I know they say a certain serving of fruit and vegetables contains so much, but,
Right, so I think that I think that if you're a diabetic, you have to watch how much fruit you take in and account for that. But in general, if you think about what our ancestors did, I mean, our ancestors had a healthy diet of fruits and vegetables and not a lot of meat. And you don't need meat all the time. So many people think we need meat. You don't need meat. Deers and antelopes eat grass and stuff, and they don't need meat. So I think that you probably can't get into trouble. Now, you could gain weight eating a lot of fruit. I mean, you still have to count calories. So people come in and say, all I eat is fruit. Well, they eat, 10 bananas and 4 oranges. Well, there's a consequence to that.
there are some products on the market that say they're natural fruit juices, and so they're not adding any additional sugar.
Right.
And it's supposed to provide 1 serving.
Sure.
Maybe 6 ounce. Is that acceptable?
Yes, I think that's perfectly acceptable. I think it's a nice way if you don't want to eat a big orange every day or carry it around. So. Yes.
Dr. Jessup, something was just mentioned. When you do when a person receives a heart transplant, the heart that the patient received, is that checked for genetics?
No.
It is not checked for
No.
genetics.
But remember, you can't.
I'm talking about a younger individual where there could have been a problem in the family that you were just talking about it a minute ago.
Right, but you can't pass that on.
Pardon me?
You can't pass that on. In other words, if you just get a heart from somebody that has a genetic abnormality, you can't catch those bad genes by having their heart. Yes. Oh, I think I better go up here because you had one question. So.
Doctor, this may be a long question, so I apologize.
Okay.
First off, I was thinking about your chart, and we, as a society, it seems like we've done a really good job with awareness about sugar. Right? Whether it's diet, it's how we look, and it impacts a lot of things. But sodium seems to be this big sleeper.
Right.
I mean, Mayor Bloomberg the other day came out now with this big sodium advocacy. But I my question is 2-part. What's the reason why there's so much salt in food? I'm talking about processed food, restaurants, etc. Is it primarily for taste, preservation? And secondly, the real question is, why isn't there more pressure brought to bear on food companies, restaurants? Because if you try to limit your salt intake to 1,500 milligrams, and you're traveling, you're in business, you go out, you're eating any kind of processed food, even the most natural, all-natural processed food, the amount of salt per serving is just off the charts.
Right. Really hard. So those are excellent questions. I think the reason food manufacturers put salt in food is because, number one, it helps preserve them. But there are, nowadays, there's better ways you can preserve foods without sodium. And number two, because we want it there. I don't know how many of you know about Gerber baby food, but they put salt in the Gerber baby food that most of us ate. So we humans get a taste for salt. Animals do too. That's why they put salt licks out for deer and things. And when we like salt and we get used to salt, and then food tastes awful without salt. I mean, there are patients that just say, I don't want to live anymore if I have to eat this food without sodium. I know nobody in this room ever but I have heard it more than once in my life. And it's because we don't think food tastes good without sodium. And so manufacturers are afraid to make food without sodium because nobody will buy it. So that's the problem. And then I alluded to the issue, can we put pressure on them? I mean, in this country, let's just take something totally not controversial, like gun control. One view is guns are bad, we shouldn't let people have them, and you can get a lot of arguments. I suspect there'll be a lot of arguments in this room. Well, how about if I say sodium's terrible, you shouldn't have a lot of sodium, people will say, don't you tell me what I can eat and what I can't eat. Just like people said, don't you tell me where I can smoke or I can't smoke. Don't you tell me what my weight should be. So we are a diverse country, and we feel that we can make our own choices. And that's fine. The problem is, as you said, and I'll finish that by saying, we can't make choices about what we eat now. Because if you try to go out and buy any processed food, there's a lot of sodium in it. So what we're trying to do through advocacy efforts is say, we're not trying to tell people what to buy. We're trying to say you have to make food that doesn't have sodium in it so people can make a choice. Because we're not all going to go out and grow our own food and eat salad every day. I mean, I'm a cardiologist. I get bored with salad. I want something else too. But I don't have that much time to be whatever you have to do to cook. Something. There must be something involved, so I look backwards, and it's really hard to find low sodium. So I would love more choices, but I think we all have to work on that and keep saying, I want food with low sodium. Go to your grocery store and say, how come I can't find any good low sodium choices here? When are you going to buy it? I'm not going to come here anymore if you don't stock some low sodium choices. I think this is one simple thing that we all can do, is really demand good low sodium. And go to your restaurant and say, I'm not eating here anymore. Did you notice that I come here every week and you don't have any low sodium foods? Most of the big chains now have hard, healthy foods. You may not want it. You go, there's no sodium and no cheese and no nothing on it. I don't want this, but it's out there now. So people are hearing, and it is possible. Now the final good bit of news, and it passed the hour, so I probably should stop, is your taste buds get better. If you can go 5 days without a lot of sodium, you won't crave it anymore. So 5 days, it's a long 5 days. But you can do it, and then you won't crave it so much. So our body adapts very quickly. It's just very hard to get through that first change. Should I stop now, Jim, or anyone?
I think it's up to them, not to me. I got plenty of recording time.
I think if you've got a few more questions, you can still take them.
Okay. Any other questions here? Yes.
I had a question about aspirin as a way to prevent heart disease. What do you feel about that?
So thank you. So the question was, how does aspirin prevent heart disease? What aspirin does is prevent one of the cells in our blood system called platelets from sticking together. And strokes, some strokes, and heart attacks, most heart attacks are caused by blood clots. So there's the platelets stick together and they form a blood clot in the artery, either in our head or in our heart, or in our legs if we have that. So that's why when you have chest pain, or you see all the commercials on the television about, I had a heart attack, the first thing they did was give me an aspirin, because that makes those platelets less sticky. But just because aspirin can be bought anywhere doesn't mean it doesn't have side effects. So aspirin, even just one a day, does have some risks of bleeding in your gastrointestinal tract, can cause hemorrhage. So they've done a lot of studies, and in fact there was a big scientific statement last year about who should take aspirin and who shouldn't. And there are a lot of people with established vascular disease, meaning you've had a heart attack or you've had a stroke or you've had a peripheral vascular. Many of those patients should take aspirin. Almost always it's a baby aspirin. If there's nothing wrong with you, if you don't have diabetes and you don't have any other risk factors, there's controversy about whether you should take an aspirin. It depends on what your risk factors are. And there's a difference between men and women. Women tend to have more complications from aspirin and derive less benefit. So, as usual, I'm going to escape answering the question completely by saying it really depends on individual discussion about risk factors, whether you should take them or not. But it is not something that we're universally saying, oh, just take an aspirin and you're not going to have a problem. Because what you might have is some GI bleeding, especially women are at higher risk. Yes?
Not a question, but I just want to congratulate you and thank you for stepping into the position in the American Heart Association.
Well, thank you.
I feel confident that you'll be able to push it in the direction that it really needs to go.
Well, I appreciate you saying that. I'm thrilled. I'm obviously extraordinarily honored, and right now I'm really scared phase because it's a huge organization, and most of us that are physicians learn about the American Heart Association through a big scientific meeting, and that's how you learn, but there is so much more. And the stakes couldn't be higher, as I've showed you. So it becomes a religion, and I want to proselytize. I want to get out there and get you to get the religion. And I think, I hope that I've been able to show you that there's many, many avenues. So I just want to give a couple more examples. There's a faith-based initiative where people go to their churches and either testify about their illness or testify about getting your blood pressure controlled or getting your cholesterol checked. There's barbershop initiatives. I know you don't go there very often, Carl, but there's where you go in and you're sitting around getting your hair done and you say, by the way, have you had your blood pressure checked? Do you know anybody in your family? And there's a growing workforce, or corporations are really embracing this sort of Life Simple 7 to have at their place of work, because employees with ideal cardiovascular health are more engaged, they're out less, they have less health care costs, so it's good business now too. So we're not only in Penn Medicine are we really trying to get out into the community and really affect not only our patients but their families and the communities, but the American Heart Association is doing this. Emil de Gama, who's one of our prevention doctors, has this great new effort that he's working on with firefighters. Firefighters, I don't know if there's any firefighters here, they have the highest incidence of death from cardiovascular disease of all the different jobs. And that's because they sit around waiting and then have to get up and run really fast. And so he has a great effort at reducing this there. So there's lots of opportunities to where you are, where you spend your time in saying, did you know, could you go take your Life Simple 7 test, find out what your risk factors are. Let's go together. I torture my sister all the time because she's overweight and she used to smoke. She'd kill me if I told you that, but and she goes with two of the people she works with, and they force each other to go and exercise together at lunchtime. And so, peer pressure, let's be an exercise buddy, let's go do this. We're humans, we like to be with one another. Yes?
Dr. Jessup, like in an old house that had lead pipes, and over the years they block and corrode and so forth. I understand in the human body, the cardiovascular system, there's now, I think it's CT, that can look into your arteries and veins and look for the buildup of plaque.
Right.
And if somebody wanted to do that, is that something that you can do? Or number two, if you can't do that, what are the signs that maybe something like that should be pursued from a health point of view?
So there's all kinds of ways to get a good estimate about whether you are developing atherosclerosis, either in your arteries of your heart, arteries of your neck, causing stroke, or in your legs. From simple things like a stress test to very new and costly things, ultra-fast CT tests. And there's a great deal of controversy about who should get that and who shouldn't, because there's kind of a, I call it the luge. So you get an abnormal test, and the next thing you know, you're getting a cath, and the next thing you know, you're getting a stent, and the next thing you know, you've got a complication from the stent, and the next thing you know, you're back in the hospital. And so, you know, was that all necessary? In this country, you know, we love to do procedures, and we love to order tests and things, and it costs a lot of money, and it isn't necessarily translating into the very best care. Now, the good news about people that have blockages in their arteries or atherosclerosis, way back a long time ago, there was a physician named Dean Ornish, who you probably heard about, and he said, and he was a lone voice in the wilderness for a long time, and said, if you follow a less than 10% fat diet, and you meditate, and you exercise, you can reverse those blockages. People laughed at him, but guess what? He's right. Mm-hmm. And there's a Pritikin centers now around the country. And so if that's one of the problems, you can actually reverse some of those blockages. Now, is it easy? No, it's not. To follow a less than 10% fat diet. I do it every February. Let me tell you, it's not fun. I'm pretty cranky by the end of the month. So I think it's possible to reverse it. And there are lots of people who go to these longevity centers like the Pritikin Center or Dean Ornish's program, where they go and they're essentially cardiac cripples, and they come back and they've exercised and they walk all the time and they meditate and they have no angina and their blood pressure goes down and they've lost weight. And, you know, is that all good? Is it a bunch of hokum? Of course not. They did Life Simple 7. Is it easy to do at that extreme? No, it's not.
Dr. Jessup, on a different line, there's another hospital up on the northern end of Broad Street that had 1,000 heart transplants, and they let the patients know what their numbers were. Recently, Penn passed the 1,000 transplant mark. Is there any way we can find out what numbers?
What numbers you mean, like what our statistics are?
No, what number we were on the transplant.
Oh.
What number we were as that, you know,
I don't know. I don't think,
99?
Yeah.
You know, were we number 278?
No, I don't know that we ever thought about that.
I know they did it at Temple.
Oh.
Excuse me, I shouldn't say that word. But you can't.
I know my number.
Is there any way we can find out what the
I
number was?
I will get back to you on that. Yes. Yes. Final question.
Over the years, we've heard a lot of controversy over caffeine, whether coffee should be decaffeinated because of high blood pressure. And now you see all the energy drinks with caffeine in them. What is it now? Are you allowed to have caffeine and still have a normal blood pressure, or?
So that's a great question about caffeine. So we used to say people that drank too much coffee, there was a cardiovascular risk. Well, probably it's because they're drinking coffee and they're not exercising, they're eating badly, and they're smoking, and it goes with the package. Over 2 caffeinated beverages a day, there's a much higher risk of cancer, actually. So that I think that if you lead an otherwise very healthy life and you want 2 cups of coffee in the morning, coffee cups, not coffee cups, not extra strong latte, double shot, whatever that you can get at Starbucks. But there's nothing wrong with that, unless, you know, there are some unusual patients who every time they even look at a cup of coffee they get arrhythmias. Well, obviously they shouldn't drink coffee, but there's no particular reason why you can't have 1 or 2 cups of coffee. Remember, there's caffeine in lots of things. There's caffeine in a lot of teas. There's caffeine in chocolate. So, you know, if you say, oh no, I don't have a lot of coffee, but you're one of these people that's having Cokes every, you know, all day. First of all, you're getting a lot of sugar, and second of all, you're getting a lot of caffeine.
We have time for maybe one more important question. Does somebody have one more?
Or not important question.
Maureen?
I have one. I'm trying to gain about 10 pounds.
Yeah, go away. We don't want to hear it. I looked at you when I said not everybody gains weight after a
But I'm supposed to be drinking 2 milkshakes a day. Should I worry about my cholesterol?
Well,
It's the milk and the ice cream and whatever.
right. So probably if you've been told to gain 10 pounds, then probably people aren't worrying about your cholesterol, so I think it's all right. It's not in general. Most people in this country don't have that problem. It's not applicable to anybody else in the room, but that's okay.
We have many here that could mentor you, Maureen.
About how to gain weight.
I want to say, I usually bring a bunch of slides, and I should have because my mind is going so many different ways with the thought-provoking things you shared with us. Not most important, I think, is the message of hope. I can remember back, it has to be in the 60s, this Parade magazine had an article about what you can do to best extend your life. The number one thing you could do was wear a seatbelt. Look at our society today. Just about everybody wears a seatbelt, but I mean, everybody's doing it. That's no longer on the list. And now we have the hope of, here's what we can attack. The other thing that I have to go back and share, and I can remember, because this is hopeful too, we've been through, most of us, heart transplant. Wow, all the things leading up to that. I can remember at the 1 year point going in to get the stress test, and that was when it was on a treadmill. And you had to fill out all the form about all your medical history. And so I did. Of course, there was a cardiac section, and I filled it all out with my history. And the nurse came and reviewed it before they put you on the treadmill. And she says, oh, not with this heart you didn't, you crossed that all out. That was one of those aha moments in my life to realize, you know what? I don't have that disease heart anymore. Life is anew.
Right, yes it is.
And I remind everybody, you know what? For all the miracles of transplantation, it does not defeat death. If you're born, you're going to die, guaranteed, right? But it does give you that extension of life. And with that comes the challenge of what to do with that life. And so when I visit patients who are waiting over there, I say, what are you doing? I'm just waiting on, hey, this is your sabbatical. This is your opportunity to think about what are you going to do with your life, and giving them the inspiration that every one of you give those people you talk to. The inspiration that life can be, some people say not normal. I say it's normal and better than normal, okay? Yeah, we take a bunch of pills. You know what? Most people getting older take a lot of pills too. And so it is a life that is inspiration for so many around us. And through that, you can be paying back in raising the awareness of, one, transplantation works. Make your decision and take action to register that to be an organ donor so that somebody else, like yourself, can be alive with grandchildren, attending weddings, dancing with your spouse, etc., for years to come because of that unknown donor. So get out there and share that. And that's the message I hope that I heard through you. And I would like to give you something from Second Chance.
Oh, thank
at the
you.
desk. Take Nature's Inspiration, a bunch of beautiful pictures of nature, and thank you very much.
Oh, thank you very much.
I don't know if you tried to get a doctor recently, especially a family doctor you call. They are so inundated with flu that they can't even make an appointment for you. But where else can you find the opportunity to spend this much time with a noted physician like this and be able to answer your questions like we have here in these beautiful programs? And so we all thank you for your time today and sharing of that knowledge and taking every one of our questions and giving us that future.
My pleasure.
A number of people have asked, this is a partnership between Second Chance Heart Transplant Support Group and Penn Medicine, and we're one of 4 chapters of Second Chance. Each of the transplant centers has a Second Chance chapter, which does things, mostly social support and also raising money for grants to help patients like yourself who run into financial difficulty. Now, it's not a lot of money, but your social workers have the opportunity to point you to Second Chance and work through Help Hope Live to get you money. We don't even know who you are. Second Chance does not see those applications. That's strictly between Debbie and her team and Help Hope Live. They follow our rules, and you can get money that way. So we raise money to do that. And so from that standpoint, I'd like to point out there's a dinner dance coming up in April, and check the website. Just do a Google on Second Chance Heart Transplant Support Group. Don't try to remember the website name. And come on out and join that. Dr. Jessup mentioned one of the other things is add some passion to your life by volunteering and paying back through the life that you have to show the world of what this is all about. And there are a lot of organizations. Let's face it, when you got involved with this, you probably knew nothing about transplant. You probably felt you were the only one that ever went through this. And you were in a room and you felt alone. Second Chance currently has over 800 members. To be a member, you have to get a heart transplant. We are local. We're just here in the Philadelphia area, a little bit of Delaware, southern Jersey. That's it. Over 800 members. Now here's the thing. That's the tip of an iceberg. There are 2,000 heart transplants done a year in this country. Out of our program here, which is typically between 50 and 60 heart transplants a year, we typically get somewhere between 0 and 1 new member to Second Chance. With that kind of happening at all centers, by the way, we have 800 members. It's quite a community, it's quite a family. You've got to come out to that dinner dance to really see people that are out more than 20 years dancing and living life to the fullest. That's kind of challenging when most people are getting transplants when they're in their late 50s, 60s. Add 20 years to that. You're not a youngster anymore. But then again, there are youngsters who are getting transplanted. Sean Duke's a great example. 22, 23 years out of the first time around after getting transplanted at the age of 19. He's the poster child for this whole program. And he liked it so much he went and got a second one a couple years ago. So it is possible. And so I just want to share all that with you, but also want to ask of this audience, now not everybody's a heart transplant recipient, with a show of hands, how many are out from their transplant less than 1 year? Hands. There's one, there's two. Okay. How many are out between 1 and 3 years? Oh, here we go. Now we're getting up there. I wanted to do the math to add up the years, but I can't keep up with that. All right, between 3 and 5 years. Wow, amazing. Between 5 and 10 years. Look at that. All right, those the youngsters, look around, okay? You're following their path. 10 to 15 years. Wow, congratulations. And Maureen, heart and lungs. I mean, you think a heart's challenging, try them both. 15 to 20 years. Way to go, Joe. What is it, 17, 16 years?
16.
16, 8 and a half, going on 19. More than 20 years. There he is. I want to point something out. 26 years is not just 6 years more than 20. Okay? You are living in an age of medicine where the results are much different, much better improvement medications, a lot more experience on behalf of the transplant team. When you meet somebody that's out 26 years, you're going back into the pioneering days. Talking to the transplant people back then, they said, we didn't know what the hell we were doing. If it worked, we kept doing it. And so when you meet somebody that's out 26 years, look at them differently than, you know, 5 5s, okay? Right. Congratulations and thank you for the inspiration you offer us every day. And so that's your challenge. What are you going to do with today? Thank you for deciding to come on out and see us here and hear the great talk and see the inspiration around you. And go on home and enjoy it. We've got some food out there. And by the way, ladies, would you come forward? Claudia, Debbie, Sally. I give out 3 different books of thank you, trying to match their needs. And these are all the same. Smile for a good reason. And so we certainly know that that's what they give us. By the way, I understand there may be a reverse merger here at Penn Medicine. They may be splitting off the social workers team to do marketing. Work they did between emails and phone calls and getting 80 people out here. Thank you, ladies. Beautiful job. With that, food is in the other room, as I understand. Am I correct, Debbie?
Yes. So we'll lead the way.
Okay, great. Follow on over.